Welcome to your complete question and answer guide for the ATI Pharmacology exam. We mirror the real exam, then break down the right answer, the wrong ones, and the theory behind it. Today's section 1 covers principles, nervous and respiratory, pharmacokinetics and routes, medication safety and high alert drugs, central nervous system medications, antidotes and substance use disorder, eye and respiratory medications. Our website offers free exam guides and practice questions designed to help you ace your ATI Pharmacology exam. Everything you need is right there, easy to access and simple to use. You'll find the link in the description below, so check it out and start studying smarter, not harder today. Alright, let's jump in. Question 1. A nurse is preparing to administer nitroglycerin by the sublingual route. Which of the following best explains why this route is selected for the medication? Your options are A. It bypasses the liver and first pass metabolism. B. It provides slow, steady absorption. C. It produces only a local oral effect. D. It reduces irritation to the stomach. Which one is it? Pause the video if you need more time. The correct answer is A. It bypasses the liver and first pass metabolism. A is correct because the sublingual route lets the medication into the bloodstream directly through vascular oral tissue, bypassing hepatic first pass metabolism. This preserves the active drug, which is the reason nitroglycerin is placed under the tongue rather than swallowed. B is wrong because sublingual delivery is valued for its speed, not slowness. The highly vascular mucosa absorbs the drug rapidly and produces a quick onset, which is the opposite of the gradual pattern that this option describes. C is wrong because a purely local effect is not the goal of this route. Sublingual nitroglycerin enters the systemic circulation to relax blood vessels throughout the body, so a tongue-only action is an inaccurate explanation of its use. D is wrong because protecting the stomach belongs to strategies such as taking a drug with food. Because the sublingual tablet never reaches the stomach at all, gastric protection cannot be the reason this particular route is chosen here. Placing a drug under the tongue lets it dissolve into a dense network of blood vessels that drain straight into systemic circulation. That single anatomical shortcut is the entire reason this route exists. A swallowed tablet crosses the gut wall and drains into the portal vein, which runs straight to the liver, where much of the dose can be broken down before ever reaching the body. A sublingual tablet instead enters veins that drain into the superior vena cava and the heart, skipping the liver entirely on that first pass. Pharmacology calls this the first pass effect. A swallowed drug is absorbed by the gut, drained through the portal vein, and metabolized by the liver before it ever reaches general circulation. Nitroglycerin swallowed this way is almost completely inactivated, which is why it must be given sublingually instead. Exam writers love testing the gap between bypassing the liver and what sublingual delivery is often mistaken for. It is not a slow, steady release, not a local effect confined to the mouth, and not a way to spare the stomach. The tablet was never headed there in the first place. Whenever you see under the tongue, sublingual, or first pass paired with rapid onset, think of one thing: rescuing a drug that swallowing would have destroyed. Question 2. A nurse is reviewing the record of a client who has liver disease and is starting a medication metabolized by the liver. Which of the following should the nurse anticipate? Your options are A. The medication will be cleared more quickly. B. A higher dose will be required. C. The drug may accumulate, requiring a lower dose. D. Stomach absorption will be increased. Take a second. Which answer would you pick? The correct answer is C. The drug may accumulate, requiring a lower dose. C is correct because impaired liver function slows metabolism, so the medication breaks down more slowly and can build up in the body. To prevent accumulation and toxicity, the provider often prescribes a reduced dose for clients who have hepatic disease. A is wrong because faster clearance describes a healthy or enzyme-induced liver, not a diseased one. Liver impairment delays biotransformation, so the drug lingers in the system rather than being eliminated more quickly than usual in this client. B is wrong because a higher dose would worsen the problem in this situation. Because a damaged liver cannot process the drug efficiently, increasing the amount would push blood levels even higher and raise the danger of toxic effects. D is wrong because liver disease affects metabolism, not gastric absorption directly. Expecting greater stomach absorption confuses a later pharmacokinetic phase with the breakdown step that hepatic dysfunction actually disrupts when this client takes the medication. Metabolism is the phase where the liver chemically converts a drug into a form the body can eliminate. When the liver is healthy, this happens at a predictable pace, and dosing schedules are built around that rhythm. A drug must be fat-soluble to cross membranes and reach its target, but that same trait makes it hard for the kidneys to flush out. The liver resolves this tension using enzymes like cytochrome P450, converting the active compound into a water-soluble form the kidneys can excrete. Test questions set traps around this idea. A damaged liver does not clear drugs faster, it does not call for a higher dose, and it disrupts metabolism, not stomach absorption. Absorption is how the drug gets in. Metabolism is the liver's middle act converting it, and excretion is how the kidneys carry it out. Liver disease strikes that middle step, slowing metabolism, causing buildup, and demanding a smaller dose. Keep the phases straight, in, through, and out. When the liver fails to convert, the drug accumulates, and the safe response is always a smaller dose or a longer interval. Question 3. A nurse is preparing to administer an intramuscular injection of a larger volume to an adult client. Which of the following sites should the nurse select as preferred for this injection? Your options are A. Deltoid site, B. dorsogluteal site, C. Intradermal forearm, D. ventrogluteal site. Before I reveal it, which one do you think is right? The correct answer is D. Ventrogluteal site. D is correct because the ventrogluteal site is preferred for intramuscular injections, especially larger volumes, because it has substantial muscle mass and lies away from major nerves and blood vessels, which makes it a safe and reliable choice for this client. A is wrong because the deltoid has a small muscle mass and is limited to small volume injections. Choosing it for a larger volume risks tissue trauma, so the deltoid is not the preferred site for the injection described in this situation. B is wrong because the dorsogluteal site is no longer recommended because of its closeness to the sciatic nerve. Selecting it introduces a real risk of nerve injury that the ventrogluteal site safely avoids, so it should not be chosen. C is wrong because the intradermal forearm is used for tuberculin and allergy testing with tiny volumes placed just under the skin. It is not an intramuscular site and cannot accommodate the larger volume injection that this client requires. Picking an injection site isn't about convenience. It's a safety decision that weighs how much muscle is available against the nerves and vessels lying underneath. The ventrogluteal site sits over the gluteus medius and minimus, a thick muscle mass free of major nerves or vessels. A clinician finds it by placing the palm on the greater trochanter and spreading the fingers toward the iliac crest, forming a reliable triangle target. Muscle mass ranks the sites. Ventrogluteal is preferred for adult volumes up to about 3 milliliters. Vastus lateralis is the go-to for infants and a solid adult backup. Deltoid handles only small volumes like vaccines, and dorsogluteal is avoided entirely because it risks the sciatic nerve. The intradermal forearm isn't even part of this ranking. It's reserved for tiny volumes like tuberculin testing, not muscle injections at all. Every other site is judged by the same rule: more muscle plus more distance from danger. Sort the sites by muscle mass and nerve safety, and the ventrogluteal rises to the top every time for a larger volume adult injection. Question 4. A nurse is teaching a client who has a new prescription for a transdermal patch. Which of the following instructions should the nurse include in the teaching? Your options are: A. Apply the patch to a hairless skin area. B. Place each new patch on the previous site. So clean the skin with alcohol before applying. D. Trim the patch to adjust the dose. What's your answer? Commit to one before I continue. The correct answer is A. Apply the patch to a hairless skin area. Is correct because transdermal patches should be applied to a clean, dry, hairless area so the medication absorbs reliably through the skin. Hair interferes with both adhesion and absorption, so selecting a hairless site supports correct and consistent dosing for the client. B is wrong because using the same spot can irritate the skin over time. Sites should be rotated with each patch change. So placing every new patch on the old location goes against safe practice and may cause local skin breakdown. C is wrong because routine alcohol cleansing is not advised because residue and skin changes can alter absorption. Washing the area with water and drying it well is the recommended preparation before applying a new transdermal patch to the skin. D is wrong because cutting a patch can damage its delivery system and release the drug unpredictably. The client should apply the patch intact. So trimming it to change the dose is both unsafe and incorrect teaching for this medication. A transdermal patch is a small medication reservoir worn on the skin, releasing its drug slowly and steadily into the bloodstream for hours or even days, turning repeated dosing into one quiet, continuous application. Pills create peaks and troughs, a surge after each dose and a dip before the next. A patch avoids that swing, delivering a near constant level while also bypassing first-pass metabolism in the liver, which matters for pain medication, hormones, and nicotine replacement. Because absorption depends on skin contact, the site must be clean, dry, and hairless, since hair lifts the adhesive and blocks drug penetration. The patch is pressed firmly onto a smooth area and the old patch is removed the moment a new one is applied. Exam writers love the small mistakes that quietly ruin the delivery. Reusing the same location irritates skin. Cleaning with alcohol alters absorption. Cutting the patch destroys its rate-controlling membrane and dumps the drug all at once. And forgetting to remove the old patch stacks dose upon dose. Unlike sublingual routes built for speed, the transdermal patch is built for endurance, and protecting that steady release means hairless skin, rotated sites, gentle prep, and never cutting the patch. Question 5. A nurse is caring for a client who is receiving an antihypertensive medication. Which of the following instructions should the nurse include to reduce the risk of orthostatic hypotension? Your options are: A. Increase intake of salty foods. B. Lie flat for hours after each dose. C. Change position slowly when standing up. D. Take the medication only when dizzy. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is C. Change position slowly when standing up. C is correct because antihypertensives commonly cause orthostatic hypotension. So rising slowly from lying to sitting to standing gives the cardiovascular system time to adjust. The simple action reduces lightheadedness and lowers the risk of falls for the client. A is wrong because boosting salty foods is not the recommended remedy and could undermine blood pressure control. Gradual position changes, rather than added sodium, are the appropriate way to manage orthostatic symptoms in a client taking these drugs. B is wrong because lying flat for hours after every dose is impractical and unnecessary. The concern arises when the client stands up, so teaching gradual position changes is far more useful than prolonged bed rest after each dose. D is wrong because antihypertensives are taken on a consistent schedule to control blood pressure, not as needed for dizziness. Waiting until symptoms appear would leave the underlying hypertension untreated and poorly managed over time for this client. Orthostatic hypotension is a sudden drop in blood pressure upon standing, defined as a fall of at least 20 millimeters of mercury systolic or 10 diastolic within 3 minutes of rising, causing dizziness, blurred vision, or fainting. Normally when you stand, gravity pulls about a pint of blood into your leg and belly veins. Baroreceptors sense the dip and fire a correction, tightening vessels and speeding the heart to restore blood flow to the brain, all within seconds. Antihypertensives are the usual culprits because they relax vessels or slow the heart, the exact responses the bare reflex needs. Diuretics thin the circulating volume, vasodilators keep vessels from clamping down, and beta blockers cap how fast the heart can speed up, leaving the standing patient's pressure to sag before the body catches up. This is a timing of movement problem, not a volume or dosing problem. Loading up on salt works against the drug. Lying flat for hours misses the point since danger strikes on standing. And skipping doses abandons blood pressure control. The real fix is changing positions slowly, pausing to let the reflex catch up. Sit up, dangle your legs, pause, then rise slowly, and the bearer reflex gets the seconds it needs to keep you steady. Question 6. A nurse is preparing to administer a high alert medication such as insulin to a client. Which of the following actions should the nurse take to promote safety? Your options are: A. Document the dose before giving it. B. Prepare doses for several clients together. C. Leave the medication at the bedside. D. Have another nurse independently verify the dose. Which would you go with? Lock it in before the reveal. The correct answer is D. Have another nurse independently verify the dose. D is correct because high alert medications carry a heightened risk of serious harm if given in error. So an independent double check by a second nurse before administration is a key safeguard that helps catch dosing mistakes before they reach the client. A is wrong because documentation should follow administration, not precede it. Charting a dose beforehand can create errors if the dose is later changed or withheld. So documenting first does not promote safety with a high alert medication. B is wrong because medications should be prepared for one client at a time to prevent mix-ups. Batching doses for several clients together increases the chance of selecting or giving the wrong drug, rather than reducing the risk of error. C is wrong because leaving medication at the bedside is generally prohibited because the nurse cannot confirm it was taken correctly. This practice raises risk and is not an appropriate safeguard for a high alert drug such as insulin. A high alert medication doesn't get used incorrectly more often than any other drug. It's just that when an error does happen, the harm can be severe or even fatal. Insulin, heparin and other anticoagulants, opioids, concentrated electrolytes, and chemotherapy agents sit near the top of the list. Safety organizations single out these drugs because a small group of medication accounts for a huge share of catastrophic harm. The signature safeguard is the independent double check. A second qualified nurse separately verifies the medication, the concentration, the dose, the pump settings, and the patient, working alone rather than simply nodding along to what the first nurse prepared. Documenting the dose beforehand only records the plan. It doesn't verify it. Preparing several patients' doses at once actually multiplies the risk of mix-ups, and leaving the drug at the bedside surrenders control entirely. None of these catches an error before it reaches the patient. When a drug can kill on a single mistake, a second independent mind checking the math before administration is the safeguard that fits. Question 7. A nurse is reviewing the history of a client who has a prescription for penicillin and a documented penicillin allergy. Which of the following actions should the nurse take? Your options are A. Administer the dose with an antihistamine. B. Withhold the dose and notify the provider. C. Give the medication and monitor closely. D. Change the route to oral administration. Don't overthink it. Which one feels right? The correct answer is B. Withhold the dose and notify the provider. B is correct because a documented allergy to penicillin is a contraindication to giving it. The nurse should withhold the medication and notify the provider so a safe alternative can be prescribed, which prevents a potentially serious allergic reaction in this client. A is wrong because adding an antihistamine does not make an allergenic drug safe to give. Pre-medicating cannot reliably prevent a serious reaction, so administering the penicillin anyway remains an unsafe choice for a client with a known allergy. C is wrong because giving the medication and simply watching exposes the client to a known allergen and risks anaphylaxis. Close monitoring does not justify administering a drug to which the client is clearly and currently allergic. D is wrong because changing the route does not remove the allergy. Whether oral or injected, penicillin can still trigger the immune reaction. So switching how the drug is given fails to address the underlying contraindication for this client. A drug allergy is not a side effect. It's an immune system reaction, where the body has learned to treat a medication as a threat, and each new exposure can trigger a bigger, faster response. It helps to separate three things nurses often blur together: a side effect, an intolerance, and a true allergy. Only a true allergy involves the immune system, and only it can escalate into a life-threatening emergency called anaphylaxis. The danger lies in the pattern. A first exposure can look harmless while the immune system quietly builds sensitivity, but a later exposure to the same drug, often penicillin, can trigger anaphylaxis within minutes. So when a new order names a drug the patient is documented as allergic to, the nurse withholds the dose and notifies the provider. Giving it while watching closely or pre-medicating on their own still exposes the patient to real danger. A documented allergy is a prediction, not a footnote. When it matches a new order, the safe action is always the same. Hold the drug and let the provider decide. Question 8. A nurse is preparing to instill eye drops into a client's eye. Which of the following actions should the nurse plan to take? Your options are A. Place the drops into the conjunctival sac. B. Drop the medication onto the cornea. C. Ask the client to look toward the floor. D. Hold the dropper against the eyelashes. Got a guess? Lock it in. The correct answer is A. Place the drops into the conjunctival sac. A is correct because eye drops should be placed into the lower conjunctival sac, which holds the medication against the eye without touching the sensitive cornea. This positioning promotes absorption and comfort for the client during installation of the drops. B is wrong because dropping medication directly on the cornea causes discomfort and a strong blend reflex. The conjunctival sac is the correct target for the drops, so applying medication onto the cornea is improper installation technique. C is wrong because the client should look up toward the ceiling, not down, during installation. Looking toward the floor moves the eye away from the sac and makes proper placement of the drop into the conjunctival sac more difficult. D is wrong because touching the dropper to the lashes contaminates the tip and can injure the eye. The dropper is held just above the eye without contact, so resting it against the lashes is incorrect and unsafe technique. Instilling eye drops isn't about hitting the center of the eye. The real target is a small pocket called the conjunctival sac, formed by gently pulling down the lower eyelid. The cornea is packed with nerve endings, so a drop landing directly on it causes an immediate blink and a surge of reflex tears that squeeze the medication right back out. The conjunctival sac, by contrast, is a tolerant reservoir that holds the drug in place until it's absorbed. Picture the eye from the side. The cornea sits over the iris, while pulling the lower lid down opens the conjunctival sac just beneath it. Good technique means tilting the head back, rolling the cornea away, and releasing the drop into that sac without the dropper ever touching the eye or lashes. The classic mistake is aiming straight at the cornea or letting the dropper rest on the eye for accuracy. Both maximize stinging and reflex loss. And touching the dropper risks scratching the eye and contaminating the bottle with bacteria. Placement and post-installation pressure serve different purposes. Getting the drop into the sac protects the eye and the dose, while pressing the inner corner afterward limits systemic absorption through the tear duct. Question 9. A nurse notes one client takes hydromorphone and another takes hydroxyzine. The nurse recognizes these as look-alike, sound-alike drugs in order to prevent which of the following? Your options are A. An allergic reaction to both medications. B. A drug-food interaction during meals. C. A delay in the onset of each drug. D. A medication error from name confusion. Which one is it? Pause the video if you need more time. The correct answer is D. A medication error from name confusion. D is correct because hydromorphone and hydroxyzine appear on the look-alike, sound-alike list because their similar names can lead to one being given in place of the other. Recognizing the similarity helps the nurse prevent a wrong medication error during administration. A is wrong because look-alike, sound-alike awareness targets confusion between drug names, not immune responses. These two medications are not paired because of any shared allergy risk, so preventing an allergic reaction is not the purpose of the list. B is wrong because the concern with these names is mixing up the drugs themselves, not how food affects them. A drug-food interaction is unrelated to the reason this particular pair appears together on the confused name list. C is wrong because onset timing has nothing to do with sound-alike naming. The list exists to stop the wrong drug from being selected and given, not to address how quickly either of these two medications begins to work. A look-alike, sound-alike error happens when two completely different drugs have names so similar that one gets mistaken for the other. Hydromorphone, a potent opioid, and hydroxyzine, an antihistamine, are the textbook pair, sharing a first few letters but nothing else. The danger exists because attention fills in gaps. Under time pressure, fatigue, or a rushed phone order, a clinician can register the familiar opening letters and let the mind supply the rest, swapping one drug for the other in either direction. Systems defend against this with deliberate safeguards. Tall man lettering capitalizes the differing parts of each name. Hydromorphone versus hydroxyzine, so the eye catches the divergence instantly. Barcode scanning matches the physical drug to the order. Listing the indication lets a pharmacist notice a mismatch, and reading orders back aloud closes further gaps. None of these rely on willpower alone. Keep the line clear. An adverse interaction is two correctly identified drugs clashing in the body, while a look-alike, sound-alike event is the wrong drug chosen before pharmacology ever comes into play. Question 10. A nurse is caring for a client who takes a medication with a narrow therapeutic index such as digoxin. Which of the following should the nurse expect as part of the plan of care? Your options are A. Routine monitoring is unnecessary. B. The client may adjust doses freely. C. Blood levels are monitored periodically. D. The drug has a wide safety margin. Take a second. Which answer would you pick? The correct answer is C. Blood levels are monitored periodically. C is correct because a narrow therapeutic index means the gap between an effective dose and a toxic one is small. Periodic blood level monitoring keeps the drug within its safe range and detects rising levels before toxicity develops in this client. A is wrong because a narrow margin is exactly why monitoring is essential. Skipping blood level checks would leave a small safety window unwatched. So stating that monitoring is unnecessary is the opposite of correct care for this medication. B is wrong because clients should never adjust narrow index doses on their own, because small changes can tip the level into toxicity. Dose changes are made by the provider after reviewing levels, not freely by the client at home. D is wrong because a wide safety margin describes a wide therapeutic index, not a narrow one. Digoxin's slim margin between effective and toxic levels is precisely what makes careful, periodic monitoring necessary. So this statement is inaccurate. The therapeutic index is the margin between a helpful dose and a harmful one. Some drugs have a wide, forgiving gap, but others leave almost no cushion between treating a patient and poisoning them. Lithium, digoxin, warfarin, and phenytoin are the names that recur in this category. With these drugs, a missed dose or a shift in clearance can tip a patient from undertreated straight to toxic. Picture the safe zone as a razor-thin band of blood concentration sitting between subtherapeutic and toxic. Because that band is so tight, prescribers draw trough levels just before the next dose to confirm the patient is sitting inside it. Metabolism, kidney function, diet, and other drugs constantly shift where a patient's level lands, so the drug can't just be dosed and forgotten. Anything that slows clearance pushes a narrow index drug toward toxicity much faster than it would a forgiving one. A narrow index isn't a reason to avoid an effective drug, and it isn't a reason to dose it rigidly. The right response is ongoing blood level monitoring, catching a rising level and trimming the dose before toxicity takes hold. Question 11. A nurse is teaching an older adult who takes several medications about polypharmacy. Which of the following statements indicates an understanding of the teaching? Your options are: A. Taking more medications lowers my side effects. B. Over-the-counter products do not need reporting. C. I can stop a medication once I improve. D. I should keep a current medication list. Before I reveal it, which one do you think is right? The correct answer is D. I should keep a current medication list. D is correct because keeping an up-to-date list of all medications, including prescription and over-the-counter products, helps providers spot interactions and prevent duplication. This is a sound strategy for an older adult who is managing polypharmacy and its many risks. A is wrong because taking more medications actually increases the chance of interactions and adverse effects in older adults. Believing that added drugs reduce side effects shows a misunderstanding of the dangers that polypharmacy creates for this client. B is wrong because over-the-counter products can interact with prescriptions and must be reported to the provider. Leaving them off the medication list hides important information, so this statement reflects incorrect understanding of safe practice for polypharmacy. C is wrong because stopping a medication without provider guidance can cause harm or allow a condition to worsen. Discontinuing a drug just because symptoms improve is unsafe and clearly indicates that the teaching was not understood by the client. As people age and collect chronic conditions, they often end up on prescriptions from several different providers, plus over-the-counter pills and supplements. Each medication makes sense on its own, but the danger appears once they all share one bloodstream. Aging slows kidney and liver clearance, so drug levels run higher, and shifting body composition changes how those drugs distribute, layered onto a long medication list. This raises the odds of interactions, duplicated therapies, and the prescribing cascade, where a side effect gets mistaken for a new illness and treated with yet another drug. Picture an older adult seeing a cardiologist, a primary provider, and a specialist, while also taking over-the-counter pills and supplements. All of it ends up in the same bloodstream, and only a shared current medication list lets any one provider see the full picture and catch a dangerous overlap. The single most protective habit is keeping a complete current medication list, including supplements, and sharing it at every appointment. That lets providers reconcile what's actually being taken against what was intended, rather than the patient stopping, doubling, or hiding a medication on their own. Fewer drugs can be safer, but that call belongs to the prescriber working from complete information. The patient's job is simply to keep and share an accurate list, because the danger of polypharmacy stays invisible until every medication is laid on the same table. Question 12. A nurse is caring for a client who is experiencing anaphylaxis from a medication. Which of the following actions should the nurse take first? Your options are: A. Establish and maintain a patent airway. B. Document the reaction in the record. C. Notify the client's family members. D. Continue the medication infusion. What's your answer? Commit to one before I continue. The correct answer is A. Establish and maintain a patent airway. A is correct because anaphylaxis can rapidly compromise breathing, so establishing and maintaining a patent airway is the first priority. The nurse also stops the offending medication and prepares epinephrine while continuing to support the client's airway and oxygenation. B is wrong because documentation is important but never comes before life-saving care. Charting the reaction first would delay airway management during an emergency that directly threatens the client's ability to breathe and maintain adequate oxygenation. C is wrong because notifying the family is appropriate later, but is not the first action during anaphylaxis. The immediate priority is protecting the airway, because this reaction can quickly progress to respiratory failure if not addressed promptly. D is wrong because continuing the infusion would keep delivering the very allergen causing the reaction. The offending medication must be stopped at once, so maintaining the infusion is exactly the wrong action for a client in anaphylaxis. Anaphylaxis is a severe, rapid, whole-body allergic reaction that can kill within minutes, as mast cells and basophils flood the body with histamine and other mediators. Blood vessels dilate and leak, the smooth muscle of the airways clamps down, and the throat and tongue swell, so a collapsing airway and a plummeting blood pressure arrive together. The airway breathing circulation order isn't arbitrary. It ranks threats by how fast they kill. A closed airway ends life in moments, so it always comes first, before breathing support and restoring circulation. Epinephrine, given into the muscle, is the definitive drug. It constricts vessels, relaxes airways, and quiets the reaction. But it does nothing if the airway has already closed. So protecting that airway is what buys time for the medication to work. Signal words like swelling tongue, wheezing, stridor, and sudden hypertension after exposure should trigger this ranking. Secure the airway first, because a lost airway kills in minutes while medication works over the moments that follow. Question 13. A nurse is caring for a client who has generalized anxiety disorder and is receiving alprazolam. Which of the following findings should the nurse identify as an expected therapeutic effect? Your options are: A. Increased alertness and energy. B. A reduction in feelings of anxiety. C. Elevated blood pressure. D. Improved muscle strength. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is B. A reduction in feelings of anxiety. B is correct because alprazolam is a benzodiazepine that enhances the inhibitory effects of GABA in the central nervous system, producing rapid relief of anxiety. A decrease in the client's anxious feelings is the expected therapeutic response the nurse should observe. I is wrong because benzodiazepines depress the central nervous system and cause sedation, not heightened alertness. Increased energy runs counter to the calming, drowsy effect that alprazolam typically produces, so it is not an expected therapeutic finding. C is wrong because alprazolam does not raise blood pressure as a therapeutic goal. Its purpose is to relieve anxiety through central nervous system depression, so an elevated blood pressure would not be an expected effect of treatment with this drug. D is wrong because improving muscle strength is not an action of this medication. Although benzodiazepines can relax skeletal muscles, the therapeutic aim in anxiety is relief of symptoms, not an increase in the client's muscle strength. Alprazolam belongs to the benzodiazepine family, medications that calm an overactive nervous system by amplifying the brain's own break-in signal, a neurotransmitter called GABA. Benzodiazepines bind to the GABA receptor and make it more responsive, so the brake presses harder and overactive neuronal firing settles down, directly calming the excess excitation that causes anxiety. The same GABA amplification produces anxiolysis, sedation, muscle relaxation, and seizure protection, a family of effects all tracing back to that single mechanism. The nuance tested is distinguishing the intended effect from the side effects that ride along. The goal is anxiolysis, the lifting of anxiety, so success is judged by watching the anxiety recede, while sedation is only watched for safety. When a patient with generalized anxiety disorder on alprazolam reports the worry loosening and calmer functioning, that eased anxiety, not sedation, is the sign the benzodiazepine is doing its job. Question 14. A nurse is teaching a client who has a new prescription for buspirone for anxiety. Which of the following information should the nurse include in the teaching? Your options are: A. Take this medication only when feeling anxious. B. This medication has a high dependence risk. C. Full effects may take several weeks to develop. D. Expect immediate relief after the first dose. Which would you go with? Lock it in before the reveal. The correct answer is C. Full effects may take several weeks to develop. C is correct because buspirone relieves anxiety slowly, with initial responses in about a week and full effects after several weeks. The client must take it on a regular schedule and understand that the benefits of this medication are not immediate. A is wrong because buspirone is taken on a scheduled basis, not as needed, because its effect builds gradually over time. Using it only during anxious moments would not provide the steady symptom control the drug is designed to give the client. B is wrong because a major advantage of buspirone is its low risk of dependence compared with other anxiolytics. Telling the client it carries a high dependence potential misrepresents the safety profile of this particular medication for anxiety. D is wrong because buspirone does not act quickly, so immediate relief is not expected after the first dose. Setting that expectation could lead the client to stop the drug prematurely before its delayed benefits have a chance to appear. Buspirone treats anxiety, but nothing about how it works resembles a benzodiazepine. Instead of amplifying GABA like a benzodiazepine, buspirone acts as a partial agonist at the serotonin 1A receptor, gradually nudging serotonin signaling toward calm rather than slamming an immediate brake. Buspirone trades speed for safety, no sedation, no high, no dependence, but relief builds slowly over roughly 2 to 4 weeks. A benzodiazepine does the opposite, calming within an hour, but carrying sedation and risk of dependence. Buspirone physically binds the serotonin 1A receptor as a partial agonist, only partially activating it, which is why its influence accumulates gradually instead of firing an instant switch. Because buspirone must be taken daily and needs several weeks to show benefit, the teaching point is patience. Expecting instant relief is what makes patients quit before the drug ever gets the chance to work. Question 15. A nurse is teaching a client who has a new prescription for an SSRI for depression. Which of the following statements indicates an understanding of the teaching? Your options are: A. I will feel better within a day. B. I can stop it once my mood improves. C. I will take it only when feeling sad. D. It may take weeks to feel better. Don't overthink it. Which one feels right? The correct answer is D. It may take weeks to feel better. D is correct because SSRIs typically require a few weeks before their full antidepressant effect develops. Understanding this delay helps the client stay adherent and avoid discouragement during the early period before the medication reaches its full therapeutic effect. A is wrong because relief within a day is unrealistic for an SSRI, because therapeutic effects build gradually over weeks. Expecting near immediate improvement reflects a misunderstanding of how this class of antidepressant medication actually works for the client. B is wrong because stopping the medication once mood improves can lead to relapse and withdrawal symptoms. Therapy continues well beyond the point of symptom relief. So this statement shows that the teaching was not fully understood by the client. C is wrong because SSRIs are taken on a regular daily schedule, not as needed during sad moments. Taking the drug only when feeling down would fail to maintain the steady blood levels that the medication requires to remain effective. Selective serotonin reuptake inhibitors raise serotonin levels in the synapse by blocking the pump that normally recycles it back into the sending cell. This lets serotonin linger longer, gradually reshaping how mood is regulated. Normally, a transporter pump quickly vacuums serotonin back into the sending neuron after it carries a signal across the synapse. An SSRI blocks that pump, so serotonin stays in the gap longer, giving downstream circuits time to adapt. Here is the puzzle. The reuptake pump is blocked within hours of the first dose, but mood doesn't live for weeks. That's because lasting benefit depends on slow receptor adaptation and circuit remodeling, not the immediate rise in serotonin, with improvement typically starting around 2 to 4 weeks and fuller effect by 6. This is unlike a benzodiazepine, which relieves anxiety almost instantly, and more like buspirone's slow build. The key teaching point is that patients must expect weeks, not days, and should never stop abruptly, especially since energy can return before mood does, raising early risk. Remember, SSRIs ask for patience because their real work is remodeling circuits, not delivering a quick chemical fix. Question 16. A nurse is monitoring a client who takes lithium for bipolar disorder. Which of the following findings should the nurse report to the provider as a sign of lithium toxicity? Your options are: A. Cause tremors and confusion. B. Mild thirst. C. A metallic taste. D. A fine hand tremor early in therapy. Got a guess? Lock it in. The correct answer is A. Cause tremors and confusion. A is correct because cause tremors with mental confusion indicate that lithium has risen into the toxic range. These are warning signs the nurse should report promptly so the provider can adjust therapy before the client's condition deteriorates any further. B is wrong because mild thirst is a common effect seen at therapeutic lithium levels and is usually transient. Because it does not signal toxicity, it does not require the same urgent reporting as cause tremors and mental confusion would. C is wrong because a metallic taste can occur with lithium, but is not a hallmark of toxicity. It lacks the neurologic seriousness of coarse tremors and confusion, which are the findings that truly warn of a rising toxic lithium level. D is wrong because a fine hand tremor is an expected effect that can often be managed without stopping the drug. It is the coarse tremor rather than the fine one that signals a lithium level climbing into the toxic range. Lithium stabilizes mood in bipolar disorder, but it has a narrow therapeutic index. The dose that helps is dangerously close to the dose that harms. Recognizing toxicity early is a core clinical skill, because small shifts in blood level separate safe from dangerous. At therapeutic levels, patients show a fine tremor and mild stomach upset, expected and tolerable. As lithium climbs into the toxic range, the picture coarsens, a coarse shaking tremor, confusion and disorientation, slurred speech, an unsteady gait, and worsening vomiting or diarrhea. At the highest levels, seizures and coma can follow. The hallmark of true toxicity is a coarsening and spreading of neurological signs, a fine tremor becoming coarse, alertness giving way to confusion. The key nuance is this: a fine tremor alone is not an emergency. It's a known companion of therapeutic lithium, but a coarse tremor paired with confusion, slurred speech, or worsening gastrointestinal symptoms signals a level climbing out of the safe window, and calls for holding the drug and checking blood levels immediately. Read early, lithium toxicity is reversible. Ignored, it can progress to seizures and lasting harm. So holding the picture of fine versus coarse, calm versus confused, is what catches it in time. Question 17. A nurse is teaching a client who takes lithium about preventing toxicity. Which of the following instructions should the nurse include? Your options are: A. Restrict all fluids during the day. B. Maintain a consistent sodium and fluid intake. C. Increase the dose if symptoms return. D. Take ibuprofen routinely for any aches. Which one is it? Pause the video if you need more time. The correct answer is B. Maintain a consistent sodium and fluid intake. B is correct because lithium levels are closely tied to sodium and fluid balance in the body. Keeping sodium and fluid intake consistent helps maintain a stable lithium level and reduces the chance of the drug climbing into the toxic range. A is wrong because restricting fluids promotes dehydration, which concentrates lithium and raises the risk of toxicity. Adequate and steady fluid intake is advised, so limiting all fluids is the opposite of safe teaching for a client taking lithium. C is wrong because clients should never raise the dose on their own, because doing so can quickly produce a toxic lithium level. Dose changes belong to the provider after reviewing blood levels, which makes self-adjustment an unsafe instruction. D is wrong because NSAIDs, such as ibuprofen, increase lithium reabsorption and can lead to toxicity. The client should avoid routine ibuprofen use, so recommending it as a remedy for aches would be harmful guidance for this client. Lithium safety in the body hinges on a hidden partnership with salt. The kidneys treat lithium almost exactly like sodium, and that shared handling is the key to understanding how toxicity happens. Inside the kidney, sodium and lithium travel the same reabsorption route. When the body senses low sodium or dehydration, the kidneys hold onto sodium tighter, and lithium gets pulled back into the bloodstream right along with it, pushing levels higher. Several everyday situations can tip the balance. Sudden low sodium diets, dehydration from heat or exercise, vomiting, diarrhea, or illness, and certain diuretics or anti-inflammatory pain relievers. Each of these shifts sodium and water handling in a way that concentrates lithium toward toxic levels. The goal is never to slash sodium or binge on it, and never to swing between dehydration and overhydration. Steady, predictable sodium and fluid intake is what keeps the lithium level anchored where it belongs. Recognizing toxicity means catching tremor and confusion after the level has already climbed, but preventing it means protecting sodium and fluid balance so that climb never starts. Consistency is the teaching that keeps the match away from the fuel. Question 18. A nurse is caring for a client who takes a first-generation antipsychotic and develops a sudden high fever, muscle rigidity, and altered level of consciousness. Which of the following should the nurse identify as the priority action? Your options are A. Encourage rest and reassess later. B. Administer the next scheduled dose. C. Stop the antipsychotic and notify the provider. D. Apply warm blankets for comfort. Take a second. Which answer would you pick? The correct answer is C. Stop the antipsychotic and notify the provider. C is correct because high fever, muscle rigidity, and a decreased level of consciousness signal neuroleptic malignant syndrome, a life-threatening emergency. The priority is to stop the antipsychotic and notify the provider so urgent, supportive treatment can begin without any delay. A is wrong because resting and reassessing later dangerously delays care for a medical emergency. Neuroleptic malignant syndrome can progress to coma, so waiting rather than acting immediately places the client at serious risk of harm or death. B is wrong because giving another dose would worsen the very reaction that is causing the crisis. The offending antipsychotic must be withheld at once, so administering more of it is exactly the wrong action for this client. D is wrong because warm blankets would raise the client's already dangerous body temperature. Cooling measures, not warming, are needed during the syndrome, which makes applying warm blankets a harmful action in the setting of a high fever. Neuroleptic malignant syndrome is a rare but life-threatening reaction to antipsychotic medications, especially the older first-generation drugs that block dopamine strongly. Recognizing it fast is the difference between recovery and death. Dopamine pathways normally regulate both movement and body temperature. When antipsychotics block them abruptly, muscle control and temperature regulation spiral out of control together, so muscle seize into rigidity while the brain's thermostat fails to cool the body down. The classic picture includes a sudden high fever, severe lead pipe muscle rigidity, and a changing level of consciousness sliding toward confusion or stupor. The autonomic nervous system destabilizes too, causing a racing heart, swinging blood pressure, and heavy sweating, often with a sharply elevated muscle enzyme on labs. The response is immediate. Stop the antipsychotic at once. Notify the provider without delay. Then follow with supportive care such as cooling the body, restoring fluids, and medications to counter rigidity. Keep this contrast clear. Neuroleptic malignant syndrome is sudden, febrile, and life-threatening, demanding immediate cessation of the drug. The late movement disorders from the same drug class develop over months and never come with fever. Question 19. A nurse is assessing a client who has taken a first-generation antipsychotic for several months and notices lip smacking and involuntary tongue movements. The nurse should identify these findings as which of the following? Your options are A. Acute dystonia, B. Orthostatic hypertension, C. An expected therapeutic response, D. Tardive dyskinesia. Before I reveal it, which one do you think is right? The correct answer is D. Tardive dyskinesia. D is correct because involuntary movements of the tongue and face, such as lip smacking, appearing after months of antipsychotic use or characteristic of tardive dyskinesia, a late extrapyramidal effect. The nurse should report these findings to the provider for evaluation. A is wrong because acute dystonia involves sudden, severe muscle spasms of the neck, face, or back within hours to days of starting therapy. The slow onset and the lip-smacking pattern described here for tardive dyskinesia instead of acute dystonia. B is wrong because orthostatic hypotension causes dizziness on standing, not involuntary facial movements. It is a cardiovascular effect of the medication and does not explain the lip smacking and tongue motions that the nurse observed in this client. C is wrong because involuntary facial movements are never a desired effect of antipsychotic therapy. These are adverse extrapyramidal signs that develop with long-term use, so labeling them as an expected therapeutic response would be incorrect for this client. Tardive dyskinesia is a movement disorder that emerges only after long-term use of antipsychotics, especially first-generation dopamine blockers. The word tardive means late, and that timing is the whole story. This condition develops slowly, over months or years, not days. The disorder comes from the brain adapting to prolonged dopamine blockade. Receptors starved of signal for so long become supersensitive, and that supersensitivity is thought to drive the involuntary movements. The very mechanism that treats psychosis eventually produces this delayed cost. The movements have a recognizable signature centered on the face and mouth, lip smacking, tongue protrusion or writhing, chewing motions, facial grimacing, and rapid blinking. Limbs and trunk can join in with slow, twisting movements, and the person is usually unaware they're happening. The key nuance is timeline and the absence of fever. Tardive dyskinesia requires months of therapy and shows no fever or rigidity, unlike the febrile, rigid emergency that can strike early. Sorting by timeline and by fever keeps a slow movement disorder from being mistaken for an acute crisis. Because tardive dyskinesia can become permanent, regular screening and the lowest effective dose are the best defenses, and recognizing it early offers the best chance of limiting lasting harm. Question 20. A nurse is reviewing the laboratory plan for a client who takes clozapine. Which of the following laboratory values is most important for the nurse to monitor with this medication? Your options are A. White blood cell count, B. Serum sodium, C. Blood urea nitrogen, D. Serum calcium. What's your answer? Commit to one before I continue. The correct answer is A. White blood cell count. Is correct because clozapine can cause a granulocytosis, a dangerous drop in white blood cells that leaves the client vulnerable to infection. Regular white blood cell monitoring is essential, so the medication can be stopped promptly if the counts fall. B is wrong because serum sodium is not the primary concern with clozapine therapy, while sodium balance matters for other drugs. The life-threatening risk with clozapine is bone marrow suppression, which is detected through the white blood cell count. C is wrong because blood urea nitrogen reflects kidney function and is not the key value to follow during clozapine therapy. The serious agranulocytosis risk makes the white blood cell count the most critical laboratory result to monitor for this client. D is wrong because serum calcium is unrelated to the main danger posed by clozapine. The drug's potential to cause agranulocytosis is why the white blood cell count, rather than the calcium level, must be monitored closely during therapy. Clozapine is a powerful antipsychotic used only after other drugs fail, but it carries a hazard so serious that it shapes the entire way the drug is prescribed. Clozapine can silently suppress the bone marrow, causing neutrophils, the white blood cells that fight bacterial infection, to collapse. Without them, an ordinary infection can turn overwhelming and deadly before the patient even feels sick. Neutrophils are made in the bone marrow and travel through the blood to hunt down bacteria. Clozapine's danger is that it can quietly shut down this production line, leaving the body undefended. The safeguard is strict blood monitoring, a baseline before treatment starts, weekly checks of the white blood cell and absolute neutrophil count, and only gradual spacing out once results stay stable. If counts fall too low, the drug is held or stopped immediately. Unlike lithium, which is monitored by measuring drug levels in the blood, clozapine is monitored by tracking the body's own infection-fighting cells. The danger isn't toxicity, it's a silently suppressed immune defense, and that's why the blood count is the value that matters. Question 21. A nurse is caring for a client who is experiencing alcohol withdrawal. Which of the following medications should the nurse anticipate administering to reduce withdrawal manifestations and seizure risk? Your options are A. Naloxone, B. Disulfiram, C. A benzodiazepine, D. Methadone. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is C. A benzodiazepine. C is correct because benzodiazepines are first line for alcohol withdrawal because they ease symptoms, lower the seizure risk, and provide substitution therapy. The nurse should expect a benzodiazepine to be ordered to help keep the client's vital signs stable during withdrawal. A is wrong because naloxone reverses opioid effects and has no role in alcohol withdrawal. It would not relieve the tremors, agitation, or seizure risk that benzodiazepines address, so it is not the medication the nurse should anticipate here. B is wrong because disulfiram is used for abstinence maintenance after withdrawal and causes an unpleasant reaction if alcohol is consumed. It is not given to treat the acute withdrawal manifestations that this client is currently experiencing during alcohol withdrawal. D is wrong because methadone is used for opioid withdrawal and maintenance, not alcohol withdrawal. It does not target the seizure risk and the autonomic symptoms that occur during alcohol withdrawal, so it is not the appropriate anticipated medication. Alcohol withdrawal happens when a brain that has adapted to constant alcohol suddenly loses it, and benzodiazepines are what carry a patient safely through that crisis. Understanding why they fit so precisely starts with what alcohol does to the brain over time. Alcohol quiets the nervous system by enhancing GABA, the brain's main inhibitory messenger. Over time, a brain soaked in alcohol turns down its own GABA activity and turns up excitatory signaling to compensate. So when the alcohol suddenly stops, that compensation is left unopposed. The underbraked, overexcited brain produces the withdrawal syndrome, tremors, sweating, a racing heart, rising blood pressure, and agitation, escalating at its worst to seizures and delirium tremens. This is a genuine medical emergency because severe withdrawal can kill. Benzodiazepines work because they enhance that same GABA signal, restoring the lost inhibition and standing in for alcohol, while the nervous system slowly readjusts. The shared action, cross-tolerance, is why they prevent withdrawal seizures and settle delirium tremens, with the dose tapered down as the brain relearns its own balance. The key nuance is that this is targeted replacement of a specific lost signal, not arbitrary sedation. In withdrawal, the benzodiazepine safely fills the gap left by missing alcohol, whereas combining the two during ordinary drinking would dangerously stack their depressant effects. Question 22. A nurse is caring for a client who is experiencing opioid toxicity with respiratory depression. Which of the following medications should the nurse anticipate administering? Your options are Flumazine, B. Naloxone, C. Atropine, D. Dantrolene. Which would you go with? Lock it in before the reveal. The correct answer is B. Naloxone. B is correct because naloxone is a specific opioid antagonist used to reverse respiratory depression, and other signs of opioid toxicity, The nurse should anticipate giving naloxone to restore adequate breathing and reverse the opioid effects in this client. A is wrong because flumazenil reverses benzodiazepine toxicity, not opioid toxicity. It would not counteract the respiratory depression caused by an opioid. So it is the wrong antidote for a client experiencing opioid toxicity with slowed breathing. C is wrong because atropine is used to treat cholinergic excess and a slow heart rate. It does not reverse opioid effects. So atropine would not help a client whose breathing is depressed because of opioid toxicity in this situation. D is wrong because dantrolene relieves malignant hypothermia and muscle spasticity. It has no action against opioids, which makes it an inappropriate choice for reversing opioid toxicity and the respiratory depression that this client is experiencing. Opioid toxicity is an overdose state where too much opioid floods the receptors that control breathing, and naloxone is the antidote built to reverse it. Opioids relieve pain by binding receptors in the brain and spinal cord, but those same receptors sit in brainstem centers that drive respiration. Push them too hard, and the result is a triad: depressed breathing, pinpoint pupils, and a sinking level of consciousness. Respiratory depression is the true danger because that is what kills. Naloxone works by physically outcompeting the opioid at its receptor. As a pure opioid antagonist, it binds the receptor and blocks it without activating it, prying the opioid loose so respiratory drive can return within minutes. The critical nuance is that naloxone's effect can fade in tens of minutes, well before a long-acting opioid clears the body. When the antidote wears off first, the patient can slide back into respiratory depression, demanding repeat dosing and close monitoring. Oxygen and airway support help the patient breathe, but only naloxone removes the opioid from its receptors. Because that reversal is temporary, watching for the opioid's return is just as important as giving the antidote itself. Question 20. A nurse is teaching a client who takes disulfiram for alcohol use disorder. Which of the following products should the nurse instruct the client to avoid? Your options are A. Caffeinated coffee, B. Aged cheeses, C. Dairy products, D. Mouthwash containing alcohol. Don't overthink it. Which one feels right? The correct answer is D. Mouthwash containing alcohol. D is correct because disulfiram causes a severe reaction when combined with any alcohol, including hidden sources. Alcohol-containing mouthwash can trigger nausea, flushing, and palpitations, so the client must avoid it along with other products that contain alcohol. It is wrong because caffeinated coffee does not contain alcohol and does not provoke a disulfiram reaction. The concern with disulfiram is exposure to alcohol, so coffee is not the product the client must avoid while taking this medication. B is wrong because aged cheeses are a concern with monoamine oxidase inhibitors because of tyramine, not with disulfiram. Disulfiram reacts specifically with alcohol, so aged cheese is not the relevant restriction for a client taking this drug. C is wrong because dairy products do not contain alcohol and are not linked to a disulfiram reaction. The teaching for this client focuses on avoiding all sources of alcohol, which ordinary dairy products are not in this case. Disulfiram treats alcohol use disorder not by curbing craving, but by turning any drink into a punishing experience. To understand why patients must avoid alcohol so completely, we need to look at how the drug rewires alcohol metabolism. Normally, the body breaks down alcohol in two steps. First into toxic acetaldehyde, then into a harmless byproduct. Disulfiram disables the enzyme responsible for that second step, so acetaldehyde piles up instead of clearing, poisoning the body's handling of alcohol. The buildup produces a swift, miserable reaction, flushing and throbbing in the head, a pounding heartbeat, nausea and vomiting, sweating, and a drop in blood pressure that leaves the person weak and dizzy. This reaction is reliable enough to serve as a standing deterrent against drinking. Because even small amounts trigger the reaction, patients must avoid every hidden source of alcohol. Not just drinks, mouthwash, cough syrup, aftershave and cologne absorbed through skin, hand sanitizer, vanilla extract, and certain sauces or desserts. A swish of mouthwash alone can set off the reaction. This caution doesn't end when the drug is stopped. The reaction can occur for up to 2 weeks after the last dose. And keep the mechanism straight. Disulfiram doesn't sedate like combining 2 depressants would. It poisons acetaldehyde clearance, turning alcohol itself into the danger. Question 24. A nurse is teaching a client who has a new prescription for a benzodiazepine for short-term insomnia. Which of the following instructions should the nurse include? Your options are: A. Avoid alcohol while taking this medication. B. Take the medication with a high-fat meal. C. Double the dose if sleep does not come. D. Drive as usual the morning after a dose. Got a guess? Lock it in. The correct answer is A. Avoid alcohol while taking this medication. A is correct because benzodiazepines depress the central nervous system, and alcohol intensifies this effect, which raises the risk of severe respiratory depression. The nurse should instruct the client to avoid alcohol completely while taking the medication for insomnia. B is wrong because high-fat meals can slow the absorption of some benzodiazepines, but taking the drug with fatty food is not the key teaching point. The critical instruction is to avoid alcohol, not to pair the dose with a fatty meal. C is wrong because doubling the dose can cause dangerous oversedation and respiratory depression in the client. Clients should take only the prescribed amount, so increasing the dose on their own when sleep is slow to come is unsafe guidance. D is wrong because benzodiazepines can cause lingering drowsiness and impaired coordination into the next day. The client should avoid driving until the sedating effects fully wear off. So driving as usual the next morning could be hazardous. Combining a benzodiazepine with alcohol isn't just adding 2 risks together, it can multiply them. Both drugs depress the central nervous system, and taken together they push far harder on the same brake pedal than either one alone. A benzodiazepine works by boosting GABA, the brain's calming messenger. Alcohol depresses the same nervous system through overlapping routes. Because both converge on the brainstem centers that control breathing and consciousness, the combination can turn ordinary drowsiness into stupor and slowed breathing into respiratory failure. This isn't like one drug irritating the stomach while another thins the blood. It's 2 agents pressing on the exact same accelerator of sedation, so the safety margin each drug has on its own shrinks dramatically when they meet, even at modest doses. In alcohol withdrawal, the benzodiazepine safely replaces alcohol's effect under medical supervision. In everyday use, adding alcohol on top of the benzodiazepine stacks 2 depressants into one dangerous load. So the same drug flips from treatment to threat depending on whether alcohol is in the picture. Whenever a scenario tests what to tell a patient starting a benzodiazepine, the answer rooted in the shared depression is simple. Avoid alcohol entirely for the duration of treatment. Question 25. A nurse is caring for a client who takes levodopa and carbidopa for Parkinson's disease. Which of the following findings should the nurse identify as an expected therapeutic effect? Your options are: A. Increased rigidity and tremor. B. Worsening shuffling gait. C. Reduced bradykinesia and improved movement. D. A faster decline in motor function. Which one is it? Pause the video if you need more time. The correct answer is C. Reduced bradykinesia and improved movement. C is correct because levodopa and carbidopa restore dopamine activity in the brain, which relieves bradykinesia, tremor, and rigidity. Improved movement and greater ease with daily activities are the expected therapeutic effects of this combination medication for the client. A is wrong because increased rigidity and tremor would indicate that the medication is not working. The goal of levodopa and carbidopa is to lessen these motor symptoms, so worsening them is the opposite of the expected therapeutic effects. B is wrong because a worsening shuffling gait reflects uncontrolled Parkinson's disease rather than effective treatment. The therapy is intended to improve gait and mobility, so this finding would not be expected when the medication is working well. D is wrong because the medication relieves manifestations even though it does not halt disease progression. A faster decline in motor function is not the intended outcome and would suggest that the drug is failing to provide its expected benefit. Parkinson's disease develops when dopamine-producing brain cells die off, robbing the brain of the chemical that controls smooth movement. Levodopa and carbidopa together are the cornerstone treatment designed to restore that missing dopamine. Dopamine can't cross the blood-brain barrier, so levodopa is used as its precursor instead. But levodopa tends to convert into dopamine too early out in the body, wasting the dose and causing nausea. So carbidopa blocks that premature conversion, letting more levodopa reach the brain where it's actually needed. As brain dopamine is replenished, the classic motor problems ease, bradykinesia, rigidity, and tremor all lessen. The patient moves more freely, walks more steadily, and manages daily tasks with less struggle. The real measure of success is functional motor improvement, not mood or lab values, and not cosmetic quirks like darkened sweat or urine, which are benign side effects. When a patient rises from a chair more easily, walks with a longer stride, and buttons a shirt without struggle, that returning movement is the direct evidence the dopamine replacement strategy is working. Question 26. A nurse is teaching a client who has Parkinson's disease and takes levodopa and carbidopa. Which of the following statements indicates an understanding of the teaching? Your options are A. I should eat high-protein meals with doses. B. I will stop the medication if better. C. This medication will cure my Parkinson's disease. D. My sweat and urine may harmlessly darken. Take a second. Which answer would you pick? The correct answer is D. My sweat and urine may harmlessly darken. D is correct because levodopa can cause a harmless darkening of sweat and urine in the client. Recognizing this as an expected, benign effect reassures the client and reflects correct understanding of the known and harmless effects of the medication. A is wrong because high-protein meals can delay levodopa absorption and reduce its effect on symptoms. The client should avoid pairing doses with high-protein foods, so this statement reflects a misunderstanding of the teaching about this medication. B is wrong because stopping the medication when feeling better can cause symptoms to return and should be avoided. Therapy is continued under provider guidance over the long term, so the statement is incorrect and shows a knowledge gap. C is wrong because levodopa and carbidopa relieve symptoms but do not cure Parkinson's disease or stop its progression over time. Believing that the drug is curative shows that the teaching about its purpose was not understood by the client. Levodopa and carbidopa can turn a patient's sweat, urine, and even saliva a brownish or reddish-black tint. It looks alarming, but it's completely harmless. Levodopa is metabolized into darkly pigmented byproducts, and those byproducts leave the body through sweat, urine, and saliva. The color is simply the visible trace of the drug being processed and eliminated, not a sign of bleeding, infection, or organ damage. Picture a patient noticing tinged toilet water and a stained collar days into treatment. Forewarned that this is expected, The patient shrugs it off and keeps taking the medication, instead of panicking and stopping a drug that is steadily restoring movement. The real skill is sorting the harmless from the meaningful. Dark discoloration is just cosmetic, while the true benefit is smoother movement, and the genuine cautions are movement fluctuations and low blood pressure on standing. When a patient asks about darkened fluids on levodopa, the correct teaching is reassurance. This change is expected and requires no action. Question 20C. A nurse is caring for a client who has myasthenia gravis and takes neostigmine. The client develops increased weakness with drooling, watery eyes, and abdominal cramping. Which of the following should the nurse suspect? Your options are A. Cholinergic crisis from excess medication. B. Worsening disease requiring a higher dose. C. An allergic reaction to the medication. D. Reduced absorption of the medication. Before I reveal it, which one do you think is right? The correct answer is A. Cholinergic crisis from excess medication. Is correct because muscle weakness combined with heavy cholinergic signs such as drooling, tearing, and cramping indicates a cholinergic crisis from too much neostigmine. The nurse should withhold the next dose and notify the provider promptly about these findings. B is wrong because a myasthenic crisis from too little drug also causes weakness, but it would not flood the client with saliva, tears, and abdominal cramps. Those extra secretions are what distinguish a cholinergic overdose from undertreatment here. C is wrong because an allergic reaction would more likely bring rash, swelling, or breathing difficulty rather than heavy secretions, a picture dominated by drooling, tearing, and abdominal cramping points to cholinergic excess instead of a hypersensitivity reaction. D is wrong because poor absorption would simply let the client's weakness return without any added secretions. The drooling and abdominal cramping show that the drug is very much active in the body, not failing to reach the system. In myasthenia gravis, the body attacks the receptors muscles use to hear nerve signals. So acetylcholine is released normally but has fewer receptors to act on, causing fatigable weakness. Neostigmine works by blocking the enzyme that breaks down acetylcholine, letting the messenger linger longer and reach the remaining receptors, amplifying a weakened signal back into muscle strength. But too much of the drug swings the system the other way, causing cholinergic crisis, excessive salivation, tearing, sweating, urination, and diarrhea, plus constricted pupils, a slowed heart, cramping, and weakness that can threaten breathing. The key nuance is telling overdose from undertreated disease. Both cause weakness, but only cholinergic crisis comes wrapped in the extra signs of excess acetylcholine. The opposite pattern of an anti-cholinergic drug, drying secretions and speeding the heart. Recognizing that cluster of excess tells you the weakness is a crisis of too much medication, meaning giving more drug would deepen the danger rather than help. Question 28. A nurse is caring for a client who takes phenytoin for a seizure disorder. Which of the following findings should the nurse monitor for as an adverse effect of long-term use? Your options are A. Yellowing of the sclera, B. A persistent dry cough, C. Overgrowth of the gums, D. Loss of hair. What's your answer? Commit to one before I continue. The correct answer is C. Overgrowth of the gums. C is correct because phenytoin commonly causes gingival hyperplasia, an overgrowth of gum tissue, with long-term use. The nurse should monitor for this effect and teach the client to maintain good oral hygiene in order to help reduce the gum overgrowth. A is wrong because yellowing of the sclera suggests liver problems and jaundice, which is not the classic phenytoin effect. Gum overgrowth. rather than scleral yellowing, is the hallmark long-term finding the nurse should watch for with this medication. B is wrong because a persistent dry cough is associated with certain blood pressure medications, not with phenytoin. It is not a recognized adverse effect of this anti-seizure drug, so it is not the finding the nurse should monitor for here. D is wrong because hair loss is not a typical phenytoin effect. The drug is more often linked to coarse facial features and excess hair growth. Gingival hyperplasia, an overgrowth of gum tissue, is the expected oral change with extended therapy. Phenytoin, a long-used anti-seizure medication, has a signature adverse effect, gingival hyperplasia, an overgrowth of the gum tissue. Phenytoin causes gum cells and connective tissue to proliferate, gradually swelling and thickening the tissue until it grows up over the teeth. This effect builds over months and worsens wherever plaque collects, since poor oral hygiene fuels the irritation and inflammation behind the overgrowth. The defense against gingival hyperplasia is meticulous oral care, thorough brushing and flossing, gentle gum massage, and routine dental visits. This keeps the overgrowth minimal without ever requiring the patient to stop the seizure medication. Keep the two ideas separate. Gingival hyperplasia is a local, manageable nuisance handled with a toothbrush, while the rule against abruptly stopping anti-seizure drugs is a broader safety principle that always stands. Remember phenytoin's signature link to gum overgrowth, and remember that diligent oral hygiene, not discontinuing the medication, is always the answer. Question 29. A nurse is teaching a client who has a seizure disorder and takes an anti-epileptic medication. Which of the following instructions should the nurse include? Your options are A. Stop the medication once seizures stop. B. Take the medication exactly as prescribed. C. Skip doses if you feel well that day. D. Drive immediately after starting the drug. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is B. Take the medication exactly as prescribed. B is correct because anti-epileptic medications must be taken consistently to maintain steady blood levels and prevent seizures. Teaching the client to take the drug exactly as prescribed supports seizure control and helps avoid breakthrough seizure activity over time. A is wrong because stopping the medication when seizures stop can trigger their return, sometimes severely. The drug controls but does not cure the disorder, so discontinuing it abruptly once seizures cease is unsafe for the client. C is wrong because skipping doses lowers blood levels and increases the chance of a seizure occurring. Consistent daily dosing is essential for seizure control, so missing doses on days when the client feels well undermines the therapy. D is wrong because clients should avoid driving until seizures are well controlled and the effects of the drug are known. Driving right after starting the medication could be dangerous if a seizure or excessive drowsiness occurs unexpectedly. Anti-seizure medications work by keeping a steady drug level in the blood at all times. That steady level raises the threshold that keeps seizures from starting in the first place. The medication doesn't stop a seizure that's already happening. It works ahead of time, holding the threshold high, and that protection only lasts while the blood level stays in range. When doses are missed or the drug is stopped, the blood level falls and the seizure threshold falls with it. Stopping suddenly is especially dangerous, since it can trigger status epilepticus, a prolonged seizure state that is a medical emergency. Because there's no warning sign to dose against, the drug is taken on a fixed schedule, not in response to symptoms. Feeling well or going a long time without seizures is never a reason to stop. Only the provider should guide a taper. Side effects are managed without abandoning the drug, because the real danger of a lapse isn't discomfort, it's the return of seizures. Unbroken, consistent dosing is the bedrock principle across this entire class of medication. Question 30. A nurse is caring for a client who has open-angle glaucoma and uses timolol ophthalmic drops. Which of the following techniques should the nurse teach to reduce systemic absorption of the medication? Your options are: A. Blink rapidly after instilling the drops. B. Instill the drops directly onto the cornea. C. Keep the eyes wide open afterward. D. Apply pressure to the inner eye corner. Which would you go with? Lock it in before the reveal. The correct answer is D. Apply pressure to the inner eye corner. D is correct because applying gentle pressure over the nasolacrimal duct at the inner corner of the eye reduces drainage of the drug into the systemic circulation. This limits systemic beta blocker effects, such as a slow heart rate or bronchospasm. A is wrong because rapid blinking pushes medication out of the eye and does not limit systemic absorption. Pressure on the inner corner of the eye, rather than blinking, is the technique that actually reduces systemic uptake of the drops. B is wrong because placing drops directly on the cornea causes discomfort and is improper technique. It does nothing to reduce systemic absorption, which instead requires pressing on the tear duct beside the nose after the drops are instilled. C is wrong because holding the eyes wide open does not prevent drainage of the medication into the nasolacrimal duct. Gentle closure of the eye with inner corner pressure is what limits the drug from entering the bloodstream after instillation. Timolol eye drops lower eye pressure to treat glaucoma, but timolol is a beta blocker, and beta blockers can affect the whole body if they escape the eye. The escape route is the nasolacrimal duct, an opening at the inner corner of the eye that drains tears into the nose. From there, the nasal tissue's rich blood supply absorbs the drug straight into the bloodstream, turning a local eye treatment into a systemic dose. Once absorbed, timolol can slow the heart rate, lower blood pressure, and tighten the airways, a risk that is especially hazardous for anyone with asthma or another breathing condition. The protective technique is nasolacrimal occlusion. Gently pressing the inner corner of the eye after the drop keeps the medication in contact with the eye and blocks it from draining into the nose, reducing systemic absorption and protecting the heart and lungs. Placing the drop delivers the medicine, but occluding the tear duct afterward is what keeps a beta blocker from becoming a whole body dose. Question 31. A nurse is preparing to administer otic drops to an adult client. Which of the following actions should the nurse take to straighten the ear canal? Your options are: A. Pull the auricle up and back. B. Pull the auricle down and back. C. Press firmly on the tragus first. D. Insert a cotton ball deep into the canal. Don't overthink it. Which one feels right? The correct answer is A. Pull the auricle up and back. A is correct because for an adult, the nurse pulls the auricle up and back to straighten the ear canal so the drops reach their target. This positioning promotes proper distribution of the medication throughout the ear canal during instillation. B is wrong because pulling the auricle down and back is the technique used for a young child, not an adult. Using it on an adult would not straighten the canal correctly, so it is the wrong approach for this client. C is wrong because pressing on the tragus is done gently after instillation, not before, to help the drops move inward. It does not straighten the ear canal, so it is not the action used for positioning the ear before instilling drops. D is wrong because inserting a cotton ball deep into the canal can damage the ear and is not recommended. If used at all, it is placed loosely at the outer portion, not pushed deep before the drops are instilled into the ear. Giving eardrops correctly depends on one detail of anatomy. The ear canal is curved, not straight, and that curve changes with age. Straightening it is the whole goal of proper technique. In an adult, pulling the auricle up and back straightens the canal's natural curve. In a young child, usually under 3. The canal angles differently, so the ear is pulled down and back instead. The principle is identical, only the direction changes with the anatomy. The canal curves between the outer opening and the eardrum, and drops left against that curve never reach the tissue they're meant to treat. Straightening the canal turns a drop placed at the opening into a full dose that coats the canal's length and reaches the eardrum. Exam writers love mixing up direction with age, so match up and back to adults and down and back to children. And remember, eardrops and eye drops share the language of instilling but nothing about the technique. Confusing the two misdelivers the medication. Straighten the canal, deliver the dose. That's the principle behind every correct eardrop technique. Question 32. A nurse is caring for a client who is receiving a neuromuscular blocking agent during mechanical ventilation. Which of the following is the priority nursing consideration? Your options are: A. The client cannot feel pain from the drug. B. The drug improves the level of consciousness. C. Continuous respiratory support must be maintained. D. The medication relieves the client's anxiety. Got a guess? Lock it in. The correct answer is C. Continuous respiratory support must be maintained. C is correct because neuromuscular blockers paralyze the respiratory muscles, so the client cannot breathe independently during therapy. Maintaining continuous mechanical ventilation and respiratory support is the priority in order to keep the client safe throughout the period of paralysis. A is wrong because neuromuscular blockers do not affect pain perception, so the client may still feel pain and need separate analgesia. This makes pain management a real concern rather than a reassuring feature of the drug for the client. B is wrong because these agents have no effect on consciousness or thinking at all. They paralyze the muscles without sedating the client, so they do not improve the level of consciousness as this option incorrectly states. D is wrong because these agents act only on muscle, they cannot relieve anxiety in the client. Separate sedation is required for comfort, so anxiety relief is not something this medication provides during the period of paralysis. Neuromuscular blocking agents are paralyzing drugs, and knowing exactly what they do and don't do is a matter of life and death. These drugs block the nerve signal to skeletal muscle, causing complete paralysis, but they provide no sedation, no pain relief, and no reduction in anxiety. A patient given one alone is fully awake and aware, yet unable to move a single muscle. The danger lies in one specific muscle paralyzed along with all the others, the diaphragm, which drives breathing. Because the drug paralyzes the diaphragm, breathing stops the moment it takes effect. Because the paralysis is purely muscular, care must apply everything the drug leaves out: continuous ventilation, since the patient cannot breathe, plus separate sedation and analgesia, since the patient is otherwise awake and suffering in silence. Paralysis and sedation are entirely separate effects that never travel together automatically. The blocker stills the muscles while leaving the mind untouched, so ventilation must never lapse, and sedation and pain control must always be added deliberately. Question 33. A nurse is caring for a client who takes a centrally acting muscle relaxant such as cyclobenzaprine. The nurse should monitor the client for which of the following adverse effects? Your options are: A fast heart rate, B, increased urine output, C, high blood pressure, D, drowsiness. Which one is it? Pause the video if you need more time. The correct answer is D. Drowsiness. D is correct because centrally acting muscle relaxants depress the central nervous system, so drowsiness and sedation are common adverse effects. The nurse should monitor the client for these effects and caution against activities that require full alertness while taking the drug. A is wrong because a fast heart rate is not a typical effect of centrally acting muscle relaxants. Their main concern is central nervous system depression with drowsiness, rather than stimulation of the heart, so fast pulse is not expected. B is wrong because increased urine output is not associated with these muscle relaxants, sedation and drowsiness, rather than a change in urination, are the expected adverse effects the nurse should watch for with cyclobenzaprine in this client. C is wrong because these medications tend to cause sedation and possibly low blood pressure, not hypertension. Elevated blood pressure is not an expected effect of cyclobenzaprine, so it is not the adverse effect the nurse should monitor for here. Cyclobenzaprine relaxes muscle spasms, but its most predictable effect is drowsiness. Understanding why starts with one word, central. Instead of acting on the muscle itself, cyclobenzaprine works in the brain and spinal cord, quieting the nerve activity that drives spasm. That same quieting effect sedates the whole nervous system, which is why relaxation and drowsiness arrive together, not as separate events. The sedation isn't incidental, it's baked into how the drug works. Drowsiness is the hallmark effect. Dry mouth can tag along, and because sedation compounds with alcohol and other depressants, patients must avoid driving, machinery, and sedating substances while taking it. Keep this distinct from a neuromuscular blocker. Cyclobenzaprine dims the brain, leaving the patient sleepy but breathing normally, while a blocker cuts the nerve-to-muscle signal directly, including at the diaphragm, demanding ventilation. Both relax muscle, but their risks are worlds apart. Drowsiness after cyclobenzaprine isn't a red flag. It's the predictable result of calming the central nervous system to relieve spasm. Teaching patients to expect it and to plan around it is what safe use looks like. Question 34. A nurse is teaching a client who has a new prescription for an oral muscarinic antagonist, such as oxybutynin, for overactive bladder. Which of the following adverse effects should the nurse include in the teaching? Your options are A. Excess salivation, B. Dry mouth and constipation, C. A slow heart rate, D. Increased sweating. Take a second. Which answer would you pick? The correct answer is B. Dry mouth and constipation. B is correct because muscarinic antagonists block cholinergic activity, which produces anticholinergic effects such as dry mouth and constipation. The nurse should teach the client about these effects and suggest fluids, fiber, and sugarless candy to relieve the discomfort. A is wrong because excess salivation reflects cholinergic stimulation, which is the opposite of this drug's action. Oxybutynin drives secretions through its anticholinergic effect, so increased saliva is not an effect the client should expect from this medication. C is wrong because a slow heart rate is a cholinergic effect, whereas muscarinic blockade tends to increase the heart rate instead. A slow pulse is therefore not an expected adverse effect of oxybutynin for a client with overactive bladder. D is wrong because anticholinergic drugs reduce sweating and can cause overheating, rather than increasing perspiration. Telling the client to expect more sweating would misrepresent this medication, since dry skin and reduced sweating are the actual anticholinergic effects. Oxybutynin calms an overactive bladder by blocking muscarinic receptors, the targets that acetylcholine normally activates. But those same receptors live throughout the body, so the same blockade that relieves the bladder also produces predictable side effects everywhere else. Acetylcholine normally keeps the mouth moist, the gut moving, and the pupils adjusting. Blocking its receptors flips that switch off everywhere at once, producing the classic anticholinergic signature, a body that dries up and slows down. The hallmark effects are dry mouth and constipation, the two patients notice most. The same blockade can also blur near vision, speed the heart, cause difficulty urinating, and, in older adults, produce confusion. Muscarinic receptors are scattered across the salivary glands, gut, eyes, heart, and bladder. Blocking them in the bladder to relieve urgency means blocking them nearly everywhere else too, which is why the side effects appear in so many organs at once. These effects aren't a separate problem. They're the anticipated footprint of the drug's mechanism, managed with fluids, fiber, and sugar-free candies. Remember the mirror image too. Boosting acetylcholine instead of blocking it floods the body with secretions and slows the heart. The opposite pattern entirely. Question 35. A nurse is teaching a client who has a new prescription for zolpidem for insomnia. Which of the following instructions should the nurse include? Your options are: A. Take the medication just before bedtime. B. Take the dose in the early morning. C. Stay awake for hours after taking it. D. Use the medication for long-term nightly sleep. Before I reveal it, which one do you think is right? The correct answer is A. Take the medication just before bedtime. A is correct because zolpidem acts quickly to induce sleep, so it should be taken just before bedtime when the client can allow adequate time for rest. Taking it at any other time of day risks daytime sedation and possible injury. B is wrong because taking zolpidem in the early morning would cause sedation during the client's waking hours. The drug is meant to promote nighttime sleep, so a morning dose is inappropriate and could leave the client unsafe during the day. C is wrong because the client should go to bed right after taking zolpidem because the drug works quickly. Staying awake afterward risks drowsiness, dizziness, and complex sleep behaviors, so this instruction is unsafe for a client taking zolpidem. D is wrong because zolpidem is intended for short-term management of insomnia, not for indefinite nightly use. Recommending long-term use does not reflect appropriate teaching, since the drug is meant to be used only for a short period. Zolpidem has one job: help a person fall asleep fast. Its timing instructions flow directly from how quickly and how briefly it works. As a non-benzodiazepine hypnotic, zolpidem brings drowsiness within minutes and is designed to last only through a full night's sleep. Because of that speed and short duration, it must be taken right before bed, with a full 7 to 8 hours available to sleep. If a patient takes the dose and then stays up, the drug's fast onset collides with wakefulness, producing dangerous behaviors like walking, eating, or even driving with no memory of it. Taken lying down in bed, that same fast onset becomes a safe, direct path into sleep. Think of zolpidem like a rocket that ignites the moment it's launched. It only works safely when the patient is already positioned for where it's headed, fast asleep, not up and moving. Zolpidem is built to start sleep fast and clear quickly, and like a longer-acting sedative meant for sustained calm. Matching the dose to the exact moment of lying down is what keeps this hypnotic safe and effective. Question 36. A nurse is caring for a client who is receiving propofol for sedation during a procedure. Which of the following is the priority nurse in action? Your options are: A. Encourage the client to eat a snack. B. Save an open vial for the next day. C. Monitor respiratory status continuously. D. Withhold resuscitation equipment. What's your answer? Commit to one before I continue. The correct answer is C. Monitor respiratory status continuously. C is correct because propofol causes respiratory and cardiovascular depression, so continuous monitoring of respiratory status is the priority during the procedure. The nurse must be ready to support ventilation and keep resuscitation equipment available throughout the sedation for this client. A is wrong because a client receiving sedation should not be eating, as this raises the risk of aspiration. Encouraging a snack is unsafe during propofol administration, so it is not a priority action and could endanger the sedated client. B is wrong because opened propofol vials must be used within a short window because the lipid emulsion supports bacterial growth. Saving an open vial for the next day risks infection for the client and is incorrect practice with this medication. D is wrong because resuscitation equipment must be readily available, not withheld, because of the depressant effects of propofol. Removing or withholding this equipment would endanger the client if respiratory depression developed during the sedation procedure. Propofol works within seconds and fades within minutes, and that speed is exactly why watching a patient's breathing becomes the heart of their care. Propofol depresses the central nervous system deeply. At sedating doses, it can slow or stop breathing and drop blood pressure, with no gentle warning as sedation deepens. A nurse watches oxygen saturation, the rise and fall of the chest, and the breathing rate without interruption, because a patient can go from breathing adequately to inadequately in moments. Other cautions exist too, like strict aseptic techniques since its fat-based formula supports bacteria, and watching for egg and soy allergies. But respiratory depression is the effect that can kill quickly, so it comes first. Propofol sedates deeply and can suppress the drive to breathe, unlike a neuromuscular blocker which paralyzes breathing outright. Either way, protecting the airway and breathing stays the center of care. Question 37. A nurse is caring for a client who has a new prescription for a stimulant for attention deficit hyperactivity disorder. Which of the following instructions should the nurse include in the teaching? Your options are A. Take the last dose late in the evening. B. Increase caffeine intake for better focus. C. Expect the medication to cure the disorder. D. Take the final daily dose before late afternoon. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is D. Take the final daily dose before late afternoon. D is correct because central nervous system stimulants can cause insomnia, so the final daily dose should be taken before late afternoon to limit sleep disturbance. Timing the last dose earlier helps the client rest while still benefiting from the therapy. A is wrong because taking the last dose late in the evening would worsen insomnia caused by central nervous system stimulation. The dosing schedule aims to avoid bedtime stimulation, so a late evening dose is counterproductive for the client's sleep. B is wrong because caffeine adds to central nervous system stimulation and can heighten side effects such as restlessness and a fast heart rate. The client should limit caffeine, not increase it, while taking a stimulant for this disorder. C is wrong because stimulants help manage attention deficit hyperactivity disorder, but do not cure it, and behavioral approaches are also needed. Expecting a cure from the medication reflects a misunderstanding of the overall treatment plan for this client. Stimulant medications for attention deficit hyperactivity disorder boost dopamine and norepinephrine, sharpening focus and reducing impulsivity during the day. That same arousal, though, can keep the brain switched on right when it should be winding down for sleep. Give the last dose too late in the day, and the stimulant is still active at bedtime, leaving the patient wired and unable to fall asleep. That's why the final dose is scheduled early, before late afternoon, so the effect fades by the time sleep is needed. Picture a child taking the last dose by early afternoon. The medication carries them through school and homework, then wears off by evening, allowing a normal bedtime. Had the dose come at dinner, the child would lie awake for hours, wound up by a drug still hard at work. Beyond insomnia, these drugs suppress appetite, so meals are planned around dosing, and they can raise heart rate and blood pressure, so cardiovascular status is watched. But the key teaching on timing is simple. Avoid late dosing so the stimulant doesn't steal the night's sleep. Keep the distinction clear. a stimulant is dosed early so its arousal fades before bedtime, while a hypnotic is dosed at bedtime so its sedation arrives exactly when sleep is wanted. Both match a drug's effect to the sleep-wake cycle, but they pull in opposite directions. Question 38. A nurse is teaching a client who takes a centrally acting alpha-adrenergic agonist, such as clonidine, and wants to stop the medication. Which of the following instructions should the nurse include? Your options are A. Taper the medication gradually as directed. B. Stop the medication abruptly to avoid side effects. C. Double the dose before stopping. D. Skip doses every other day to wean off. Which would you go with? Lock it in before the reveal. The correct answer is A. Taper the medication gradually as directed. A is correct because abruptly stopping a centrally acting alpha-adrenergic agonist can cause rebound hypertension in the client. The nurse should teach the client to taper the medication gradually under provider guidance in order to avoid a dangerous rise in blood pressure. B is wrong because stopping abruptly can trigger rebound hypertension rather than avoiding side effects for the client. A gradual taper guided by the provider is required, so sudden discontinuation of this medication is unsafe and should not be taught. C is wrong because doubling the dose before stopping does not prevent rebound effects and could cause excessive sedation or low blood pressure. The correct approach for this client is a gradual taper, not an increase in the dose. D is wrong because randomly skipping doses produces unstable blood levels and does not safely wean the client from the drug. A structured, slowly step-down dose under medical supervision is the appropriate way to discontinue this medication safely. Clonidine lowers blood pressure by acting in the brain, and that central mechanism is exactly why it must never be stopped abruptly. Clonidine stimulates receptors in the brainstem that reduce the sympathetic nervous system signals to the heart and blood vessels, so the heart eases, the vessels relax, and blood pressure falls. Over time, the body adapts to the suppressed sympathetic state, much like a spring held compressed for months. If clonidine is stopped suddenly, that suppression vanishes all at once and the sympathetic system rebounds, often overshooting into rebound hypertension with a rapid spike in blood pressure, racing heart, headache, and agitation. Because the withdrawal itself is the danger, clonidine must always be tapered gradually and under supervision, never stopped or skipped abruptly. Question 39. A nurse is teaching a client who has prescriptions for both an inhaled beta-adrenergic agonist and an inhaled glucocorticoid. Which of the following instructions should the nurse include? Your options are A. Use the glucocorticoid before the bronchodilator. B. Use only one inhaler each day. C. Use the bronchodilator before the glucocorticoid. D. Avoid rinsing the mouth after the glucocorticoid. Don't overthink it. Which one feels right? The correct answer is C. Use the bronchodilator before the glucocorticoid. C is correct because when both inhalers are prescribed, the beta-adrenergic agonist is used first to open the airways, which enhances the delivery and absorption of the glucocorticoid that follows. This sequence improves the overall effectiveness of the inhaled steroid. A is wrong because using the glucocorticoid first means the airways are still narrowed, which reduces how well the steroid is delivered to the lungs. The bronchodilator should come first to open the airways, so this order is incorrect. B is wrong because both inhalers are prescribed for a reason and should be used as ordered each day. Limiting therapy to a single inhaler daily would leave the client undertreated, so this is not appropriate teaching for the regimen. D is wrong because the client should rinse the mouth after an inhaled glucocorticoid to prevent oral fungal infection. Telling the client not to rinse would increase the risk of candidiasis. So this instruction is incorrect for the inhaled steroid. When a patient uses both an inhaled bronchodilator and an inhaled glucocorticoid, the order isn't preference, it's physics. The bronchodilator always comes first. The bronchodilator relaxes airway muscle and opens the passages quickly. After a short pause, the glucocorticoid rides those newly widened airways deeper into the lungs to treat inflammation. Picture a narrowed airway versus one opened by the bronchodilator. In the narrowed airway, steroid particles stall near the surface. In the widened airway, they travel deep into the small, distant airways where inflammation actually lives. Keep the distinction clear. The bronchodilator is the fast-acting opener, used first, while the glucocorticoid is the slow-acting healer, used second so it can reach deep. Reverse the order and much of the steroid stalls in still narrowed airways. So whenever a question asks which inhaler comes first, remember, the bronchodilator clears the path so the glucocorticoid can be deposited deep into the airways. Question 40. A nurse is reviewing the record of a client who has a new prescription for ipratropium by inhalation. Which of the following conditions should the nurse recognize as a contraindication? Your options are A. Hypertension, B. Peanut allergy, C. Diabetes mellitus, D. Seasonal allergies. Got a guess? Lock it in. The correct answer is B. Peanut allergy. B is correct because ipratropium preparations may contain soy lecithin, so peanut allergy is a contraindication because of cross-sensitivity. The nurse should recognize this allergy and verify the concern with the provider before the inhaled medication is administered to the client. A is wrong because hypertension is not a contraindication to ipratropium, which acts locally in the airways with limited systemic effect. The peanut allergy, rather than high blood pressure, is the key concern the nurse must recognize for this client. C is wrong because diabetes mellitus does not contraindicate the use of ipratropium. The cross-sensitivity associated with a peanut allergy is the specific contraindication the nurse must recognize before this inhaled medication is given to the client. D is wrong because seasonal allergies are not a contraindication, and the drug may even help relieve allergen-induced bronchospasm. It is the peanut allergy, not seasonal allergies, that requires caution and recognition before ipratropium is administered to this client. Why would a nurse ask an asthma patient about peanut allergies? The answer lies not in the drug itself, but in what carries it into the lungs. The concern traces to soy lecithin, a soybean-derived substance used in some aerosolized inhaler formulations. Because soybeans and peanuts are botanically related legumes, a patient allergic to one may react to the other, and to the soy-derived carrier hidden inside the inhaler. Picture the inhaler as having two separate parts: the active drug, ipratropium, which relaxes the airways, and the carrier substance that delivers it. The allergy danger rides entirely in that carrier, not in the medication doing the actual work. Think of it like blaming the delivery truck rather than the package it carries. The medication itself is safe for a peanut allergic patient, but the vehicle transporting it into their lungs is not. A documented peanut or soybean allergy can be a contraindication for inhaled ipratropium, not because of the drug, but because of its formulation. Catching that link before the first dose is the safety check that protects the very airways the drug was meant to help. Question 41. A nurse is reviewing prescriptions for a client who has asthma and a new order for a long-acting beta-adrenergic agonist such as salmeterol. Which of the following statements by the client indicates a need for further teaching? Your options are A. I will use this inhaler regularly. B. I will keep using my prescribed steroid inhaler. C. I will report if my symptoms get worse. D. I will use this inhaler for sudden attacks. Which one is it? Pause the video if you need more time. The correct answer is D. I will use this inhaler for sudden attacks. D is correct because a long-acting beta-adrenergic agonist is for long-term control and does not work fast enough to stop an acute asthma attack. Planning to use it as a rescue inhaler reflects a misunderstanding that requires further teaching from the nurse. A is wrong because using salmeterol on a regular schedule is correct, since it provides long-term control rather than quick relief of symptoms. This statement shows appropriate understanding of the medication and does not require any further teaching from the nurse. B is wrong because continuing the prescribed inhaled steroid is correct, because long-acting beta-adrenergic agonists must be paired with an inhaled glucocorticoid. This statement reflects proper understanding of the asthma regimen and does not indicate a need for more teaching. C is wrong because reporting worsening symptoms is appropriate and reflects safe self-monitoring by the client. This statement indicates that the client understands the teaching about the medication and does not signal any knowledge gap that needs correction. Long-acting beta-agonists and short-acting beta-agonists both open airways, but they are built for completely different jobs. Confusing the two is a dangerous mistake that shows up often on exams. A long-acting beta-agonist relaxes the muscle around the airways, just like other beta-agonists, but it releases that effect slowly and keeps it going for many hours. That makes it excellent for daily prevention, but far too slow to handle a sudden attack. The short-acting bronchodilator opens airways within minutes, making it the only correct choice during a sudden attack. The long-acting agent is taken on a schedule to prevent attacks before they start, and mixing up these two roles can leave a patient without rescue when they need it most. Whether fast or slow-acting, both drug types work the same way at the airway. They relax the smooth muscle wrapped around the airway, allowing the passage to widen so air can flow freely again. A patient who reaches for a long-acting inhaler during an attack is reaching for the wrong drug at the wrong moment. Teach the roles clearly. Long-acting for daily control. Short-acting always on hand for emergencies. Question 42. A nurse is caring for a client who is taking codeine as an antitussive. The nurse should monitor the client for which of the following as an adverse effect? Your options are A. Respiratory depression, B. An increased respiratory rate, C. Diarrhea, D. Excessive urination. Take a second. Which answer would you pick? The correct answer is A. Respiratory depression. A is correct because codeine is an opioid that can depress the central nervous system and slow respirations. The nurse should monitor the client for respiratory depression and be prepared to intervene if the client's breathing becomes dangerously slow while taking the drug. B is wrong because opioids slow breathing rather than speed it, so an increased respiratory rate is not an expected effect. The concern with codeine is depressed, slowed respirations, which is the opposite of the finding described in this option. C is wrong because opioids reduce gastrointestinal motility and commonly cause constipation rather than diarrhea. Diarrhea is therefore not a typical adverse effect of codeine, so it is not the finding the nurse should monitor for in this client. D is wrong because codeine is not associated with excessive urination. The key adverse effects the nurse should monitor for are respiratory depression, sedation, and constipation, rather than any change in the client's urine output while taking the drug. Codeine is an opioid, and that identity matters even when it's used simply to quiet a cough. The same opioid action that suppresses coughing can also suppress breathing, and that overlap is the key danger to understand. Codeine works by acting on the cough center in the brainstem, damping down the reflex that triggers coughing. But right next door, The same brain stem houses the centers that control breathing, and opioids depress those too. So the drug can't calm the cough without also touching the drive to breathe. Codeine's other opioid effects reinforce the same caution: sedation and drowsiness, constipation, and a risk of dependence with prolonged use, all on top of the most serious concern, respiratory depression. Every one of these traces back to the fact that this cough remedy is, at its core, an opioid. The key distinction is between an opioid cough suppressant like codeine, which carries the risk of slowed breathing, and a non-opioid suppressant, which quiets the cough without that danger. Knowing which type is in play tells you whether respiratory depression is even a concern. When a scenario names codeine for cough, the effect to monitor is respiratory depression, because it's the classic opioid hazard hiding behind a seemingly simple remedy. Question 43. A nurse is teaching a client who has a new prescription for guaifenesin. Which of the following instructions should the nurse include? Your options are: A. Limit fluid intake while taking it. B. Take the medication to suppress coughing. C. Drink a full glass of water per dose. D. Avoid all other cough preparations. Before I reveal it, which one do you think is right? The correct answer is C. Drink a full glass of water per dose. C is correct because guaifenesin is an expectorant that thins secretions, and adequate fluids enhance this effect. Drinking a full glass of water with each dose and increasing fluids helps loosen mucus so the client can cough it up more easily. A is wrong because limiting fluids works against guaifenesin, which relies on hydration to thin the secretions. Restricting water would reduce the drug's effectiveness. So this instruction is incorrect for a client taking an expectorant for chest congestion. B is wrong because guaifenesin promotes a productive cough to clear mucus rather than suppressing the cough reflex. Describing it as a cough suppressant misstates how this expectorant actually works. So this instruction would mislead the client about the medication. D is wrong because guaifenesin is often combined safely with other ingredients in cold preparations. A blanket warning to avoid all cough products is unnecessary and is not the focus of the teaching for a client taking this expectorant. Guaifenesin is an expectorant, and its job isn't to stop a cough but to change it, making it productive so it can actually clear the lungs. Thick, tenacious mucus is hard to move, and coughing against it accomplishes little while exhausting the patient. Guaifenesin reduces the stickiness and thickness of secretion so the same cough can finally shift and expel them. Picture the airway lined with thick mucus that a dry cough can't clear. Guaifenesin loosens that mucus so it becomes easier to move, turning a wasted cough into one that actually expels the secretions. Because guaifenesin thins mucus, hydration is its natural partner. Patients should drink a full glass of water with each dose and stay well hydrated overall, since water is the simplest mucus thinner there is, amplifying the drug's loosening effect. Keep the distinction clear. An expectorant loosens mucus to make a cough more productive, while a suppressant quiets the cough reflex entirely, which suits a dry, nagging cough. Confusing the two means suppressing a cough that should be clearing mucus, or trying to thin secretions when the goal was simply quiet. Question 44. A nurse is teaching a client who has been using a topical nasal decongestant, such as phenylephrine, for several days. Which of the following adverse effects results from prolonged use? Your options are: A. Sedation. B. A productive cough. C. Constipation. D. Rebound congestion. What's your answer? Commit to one before I continue. The correct answer is D. Rebound congestion. D is correct because prolonged use of a topical decongestant beyond a few days leads to rebound congestion, in which nasal stuffiness worsens. The nurse should teach the client to limit topical use to the recommended short period in order to avoid this effect. A is wrong because sedation is not the concern with topical decongestants, which tend to stimulate rather than sedate the client. Rebound congestion, not drowsiness, is the effect that results from using a topical nasal decongestant for too long. B is wrong because a productive cough is unrelated to overuse of a nasal decongestant. The hallmark of extended topical decongestant use is worsening nasal congestion, so a cough is not the adverse effect that results from prolonged use here. C is wrong because constipation is not associated with these topical agents. The problem caused by using a topical decongestant for longer than the recommended period is rebound nasal congestion, rather than any change in the client's bowel pattern. Nasal decongestant sprays work fast, but that speed hides a trap. Use them too long, and the very relief they provide can turn into a worse congestion than before. The spray works by constricting the blood vessels in the nasal lining. As the vessels narrow, the swollen tissue shrinks, the passages open, and breathing eases almost immediately. Beyond a few days, the nasal vessels adapt and start depending on the drug. When each dose wears off, they swell back worse than before, so the patient sprays again, feeding a cycle known as rhinitis medicamentosa. The central teaching is a strict limit, no more than 3 days of use. Within that window, the spray relieves congestion safely. Beyond it, rebound risk climbs and the cure becomes the cause of ongoing stuffiness. It's not the dose, but the duration that separates relief from harm. Break the cycle by stopping the spray and endure the rebound until the vessels recover on their own. Question 45. A nurse is caring for a client who takes a first-generation antihistamine such as diphenhydramine for allergic rhinitis. The nurse should monitor the client for which of the following adverse effects? Your options are A fast heart rate as the main effect. B. Drowsiness. C. Increased nasal secretions. D. Diarrhea. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is B. Drowsiness. B is correct because first-generation antihistamines cross the blood-brain barrier and commonly cause sedation in the client. The nurse should monitor for drowsiness and caution the client against activities that require full alertness while taking this type of antihistamine. A is wrong because although anticholinergic effects can occur, a fast heart rate is not the primary effect of diphenhydramine. Sedation is the hallmark adverse effect of a first-generation antihistamine, so drowsiness is the main effect to monitor for. C is wrong because antihistamines dry secretions rather than increase them, which helps relieve a runny nose. Increased nasal secretions would be the opposite of this drug's effect, so it is not an adverse effect the nurse would monitor for. D is wrong because first-generation antihistamines tend to cause constipation through their anticholinergic action rather than diarrhea, drowsiness. Not diarrhea is the key adverse effect the nurse should monitor for in a client taking diphenhydramine. First-generation antihistamines like diphenhydramine relieve sneezing and itching by blocking histamine, but their most noticeable effect is often drowsiness, not allergy relief. In the brain, histamine helps maintain wakefulness. First-generation antihistamines are small, fat-soluble molecules that cross the blood-brain barrier freely, so they block histamine's wakefulness role right along with its allergy role. First-generation drugs cross the blood-brain barrier and block wakefulness receptors, causing sedation, while second-generation drugs are built to stay outside the brain, relieving allergies with little or no drowsiness. Because drowsiness is expected, patients should avoid driving and avoid combining these drugs with alcohol or other sedatives. Older adults are especially vulnerable, facing not just sedation but anticholinergic effects like dry mouth, constipation, and confusion that raise full risk. Drowsiness isn't a rare side effect or a sign of illness. It's the predictable result of blocking histamine in the brain, and recognizing that is exactly what exam questions are testing. Question 46. A nurse is caring for a client who is receiving acetylcysteine by inhalation as a mucolytic. Which of the following adverse effects should the nurse monitor for during administration? Your options are A. Constipation, B. A slow heart rate, C. Bronchospasm, D. Increased blood glucose. Which would you go with? Lock it in before the reveal. The correct answer is C. Bronchospasm. C is correct because acetylcysteine can trigger bronchospasm when inhaled, especially in clients who have airway disease. The nurse should monitor for wheezing and respiratory difficulty and be ready to stop the drug and notify the provider if bronchospasm occurs. A is wrong because constipation is not an effect of inhaled acetylcysteine. The respiratory concern with this mucolytic is bronchospasm, which is the adverse effect the nurse must watch for closely during administration to a client with airway disease. B is wrong because a slow heart rate is not characteristic of acetylcysteine. The drug may instead cause a faster heart rate. Bronchospasm, rather than a slow pulse, is the priority adverse effect the nurse should monitor for during inhalation. D is wrong because increased blood glucose is not associated with acetylcysteine. Monitoring during inhalation should focus on respiratory effects such as bronchospasm, rather than on any change in the client's blood glucose level while receiving this mucolytic. Acetylcysteine is a mucolytic inhaled to break apart thick, sticky mucus so it can be cleared from the lungs. But the very airways it aims to help can react by tightening, a paradox at the heart of its most important hazard. Thick respiratory secretions get their tenacity from molecular links between mucus strands. Acetylcysteine chemically severs those bonds, thinning the mucus so it can be coughed up or suctioned out. The concern is that the same airways being cleared can react to the drug by tightening. This is called bronchospasm, a sudden constriction of the airway muscles, and it's especially risky in patients with reactive airways, like those with asthma. Because of this risk, a bronchodilator is often given alongside or before the mucolytic to keep airways open, and the patient is monitored closely throughout. The drug also has a distinctive rotten egg smell that can provoke nausea, but bronchospasm is the effect that truly demands vigilance. Anticipating that reaction, watching for wheezing, and being ready with a bronchodilator is the safe approach. A mucolytic breaks mucus apart directly in the airway, which is exactly why that airway response is watched so carefully. Question 47. A nurse is caring for a client who has a documented opioid allergy and a new prescription for an antitussive. Which of the following non-opioid antitussives should the nurse anticipate? Your options are A. Dextromethorphan, B. Codeine, C. Hydrocodone, D. Morphine. Don't overthink it. Which one feels right? The correct answer is A. Dextromethorphan. A is correct because dextromethorphan is a non-opioid cough suppressant that acts on the central nervous system to raise the cough threshold. It is an appropriate antitussive choice for a client who has an opioid allergy and cannot take opioid medications. B is wrong because codeine is an opioid antitussive and would be inappropriate for a client who has an opioid allergy. A non-opioid agent such as dextromethorphan is the suitable cough suppressant option for this client instead of codeine. C is wrong because hydrocodone is also an opioid and carries the same concern as codeine for a client with an opioid allergy. It is not a non-opioid alternative, so it does not fit the antitussive prescription described for this client. D is wrong because morphine is an opioid analgesic rather than a non-opioid antitussive, and giving it to someone allergic to opioids would be unsafe. Dextromethorphan, in contrast, suppresses cough without any opioid properties. Dextromethorphan quiets the cough reflex without being an opioid, and that single distinction is what makes it so valuable in practice. Like codeine, dextromethorphan acts on the cough center in the brain to dampen the reflex that triggers coughing. But unlike codeine, it does this without the opioid effects that make codeine risky. So it can be safely given to someone with an opioid allergy or another reason to avoid opioids. Both drugs work by damping down the same cough center in the brainstem. The difference is what happens elsewhere. Codeine engages the opioid system, while dextromethorphan reaches the same reflex without triggering opioid activity at all. Dextromethorphan suppresses cough at usual doses without producing the analgesia, the euphoria, the dependence, or the respiratory depression that define opioids. Because it doesn't touch the opioid system, it carries far less risk of misuse and none of codeine's signature breathing danger. When an opioid allergy or a reason to avoid opioids is documented, dextromethorphan is the classic non-opioid answer, delivering the cough relief of codeine without the opioid identity that makes codeine unsafe. Question 48. A nurse is preparing to administer promethazine and reviews the available routes. Which of the following routes should the nurse identify as preferred to reduce the risk of severe tissue injury? Your options are A. Rapid intravenous push, B. Subcutaneous, C. Intradermal, D. Intramuscular. Got a guess? Lock it in! The correct answer is D. Intramuscular. D is correct because promethazine can cause serious tissue injury, especially with intravenous use. The intramuscular route is preferred to lower this risk, and any intravenous use requires careful dilution and a large vein with slow administration to protect the client. A is wrong because a rapid intravenous push raises the danger of severe tissue damage and extravasation injury for the client. This is the route most associated with harm from promethazine, so it is not the preferred route for administration. B is wrong because the subcutaneous route is not recommended for promethazine and can cause significant tissue irritation. The intramuscular route, rather than the subcutaneous one, is the safer preferred choice for reducing the risk of tissue injury here. C is wrong because the intradermal route is used for small volume skin testing, not for administering promethazine. It is not an appropriate route for this medication, so it does not address the concern about reducing the risk of severe tissue injury. Promethazine treats nausea, allergies, and sedation, but it's also caustic to tissue, so how you give it matters as much as why you give it. Given into a vein, promethazine can cause severe injury if it leaks out or enters an artery, sometimes leading to tissue death or limb loss. Injected under the skin, it can cause necrosis at the site. Muscle tissue, by contrast, tolerates the drug far better. Picture the drug entering at 3 different depths: the vein, the skin, and deep muscle. Only the muscle route absorbs the drug reliably without exposing delicate vessel walls or skin tissue to its caustic effects. The reasoning here isn't about how fast the drug works. It's about keeping caustic medication away from tissue it could destroy. That's why, when an injection is needed, the intramuscular route is the one that protects the patient. Remember, for promethazine, choosing the intramuscular route isn't about better delivery. It's about avoiding the severe tissue injury that intravenous or subcutaneous administration can cause. Question 49. A nurse is caring for a client who is receiving an inhaled anticholinergic such as ipratropium. The nurse should monitor the client for which of the following local adverse effects? Your options are increased salivation, B, a slow heart rate. C, dry mouth. D, watery eyes. Which one is it? Pause the video if you need more time. The correct answer is C, dry mouth. C is correct because inhaled anticholinergics block muscarinic receptors, which reduces secretions and commonly causes dry mouth. The nurse should monitor for this local effect and suggest sips of water or sugar-free candy to help relieve the dryness for the client. I was wrong because increased salivation reflects cholinergic activity, which is the opposite of an anticholinergic's effect. Ipratropium dries the mouth rather than increasing saliva, so increased salivation is not a local adverse effect the nurse would monitor for here. B is wrong because a slow heart rate is a cholinergic effect, whereas anticholinergics tend to increase the heart rate instead. A slow pulse is not an expected local adverse effect of inhaled ipratropium, so it is not the finding to monitor. D is wrong because watery eyes result from cholinergic stimulation, not from anticholinergic blockade. Ipratropium reduces secretions, so dry mouth rather than tearing is the local effect the nurse should monitor for in a client receiving this inhaled drug. Ipratropium is an anticholinergic, meaning it blocks acetylcholine, the transmitter that normally tightens airway muscles and stimulates saliva production. When inhaled, it relaxes the airways, but that same blockade also dries out the mouth and throat where the drug first lands. Because the drug is inhaled, it acts mainly where it lands, in the mouth and airway tissue, rather than spreading through the bloodstream. Blocking acetylcholine there reduces saliva and keeps the airway muscles from tightening, so dryness and an odd taste are the effects patients notice most. This is the key distinction exam writers test. An inhaled anticholinergic like ipratropium stays mostly local, producing dry mouth and a bad taste. An oral anticholinergic, like a drug for overactive bladder, spreads throughout the body, causing constipation, urinary retention, blurred vision, and a fast heart rate. Because this dryness is expected and minor, management is simple: sipping water, using sugar-free candy or gum, and practicing good oral care keep patients comfortable while the medication keeps their airways open. Remember, it's the same anticholinergic blockade either way, but the route determines whether the effect stays confined to the mouth or spreads to affect the whole body. Question 50. A nurse is caring for a client who takes a second-generation antihistamine, such as loratadine for allergic rhinitis. Which of the following findings should the nurse identify as an expected therapeutic effect? Your options are A. Relief of sneezing and runny nose. B. Relief of nasal congestion. C. Increased coughing. D. A rise in blood pressure. Take a second. Which answer would you pick? The correct answer is A. Relief of sneezing and runny nose. A is correct because loratadine blocks histamine at its receptors, which relieves sneezing, itching, and a runny nose in allergic rhinitis. These improvements are the expected therapeutic effects the nurse should observe in the client who is taking this antihistamine. B is wrong because antihistamines do not relieve nasal congestion, which is instead addressed by decongestant medications. Expecting congestion relief from loratadine misjudges what this antihistamine actually treats. So congestion relief is not an expected therapeutic effect here. C is wrong because loratadine does not cause increased coughing and is used to relieve allergy symptoms in the client. More coughing would not be an expected therapeutic effect of the second-generation antihistamine. So this finding is incorrect for the medication. D is wrong because a rise in blood pressure is not a therapeutic effect of loratadine. The drug targets allergy symptoms such as sneezing and a runny nose. Rather than blood pressure, so an increase in blood pressure is not expected. Second-generation antihistamines like loratadine treat allergy symptoms by blocking histamine, the chemical that drives sneezing, runny nose, itching, and watery eyes. The key difference is where these drugs act. Older antihistamines cross into the brain and cause drowsiness, while second-generation drugs stay mostly outside the brain, blocking histamine where allergy symptoms occur without touching the brain's wakefulness signals. The therapeutic effect to recognize is the easing of sneezing, runny nose, and itching, with the patient staying fully alert, not any change in drowsiness. Think of it like a bouncer stationed outside the club rather than inside. Histamine gets blocked where allergy symptoms happen, while the brain's own histamine keeps the patient awake and clear-headed. For daily allergy management, second-generation antihistamines deliver the same symptom relief as older drugs, but let patients stay alert at work or behind the wheel. That brings today's pharmacology review to a close. If you're craving more practice, head over to our website where hundreds of free questions and complete study guides are waiting for you. There's no cost and no catch, just solid resources designed to help you learn. So click the link in the description below and dive in whenever you're ready to get started learning more. Subscribe and stay tuned for the next part. Good luck on your exam.